A very good afternoon to respected chair, faculty members, esteemed colleagues, and dear residents. On behalf of Surgery Unit 1, I warmly welcome all of you for today's clinical combined round on the topic of disruptive dysphagia. This was a rare, challenging, and interesting case, making it relevant for discussion. And we are delighted to have participation from multiple departments and hope that today's presentation will be engaging and beneficial to all. Now I invite Dr. Ambol Sood, Junior Resident Surgery Unit 1, to present the brief history of the case.
A very good afternoon to you. I am Dr. Amol Sood, junior resident in the department. Our patient is Mr. A.T. He is a 40-year-old gentleman, a resident of Muzaffarnagar, Uttar Pradesh. He presented to our OPD with the chief complaint of dysphagia and pain in the retrosternal region for 1.5 months duration. The patient was apparently well till 1.5 months back when he developed mild dull aching pain in the lower retrosternal region. The pain was associated with food intake and it was associated with dysphagia that was more to solids as compared to liquids. The pain used to get relieved spontaneously after half to 1 hour. The negative history was not pertinent. The patient was on medications for bipolar disorder for the past 3 years and was well controlled on the same. He did not have any other known comorbidity and did not give any prior surgical history. The family and personal history both were non-contributory. The patient was examined after taking consent in a well-lit room. The vitals were normal. The head-to-toe examination as well as the system-wise examination were also normal. Now at this point, we were dealing with a patient who was a case of dysphagia under evaluation and likely neoplastic in etiology. We performed routine laboratory investigations for our patient, which were all normal. We then proceeded with an upper GI endoscopy. This was done at an outside hospital and it showed a large submucosal lesion in the esophagus with smooth surface and large dilated veins. The lesion was located just above the gastroesophageal junction and the endoscope was negotiable beyond it with difficulty. Based on the endoscopy findings, a provisional diagnosis of gastrointestinal stromal tumor was made for our patient. I now invite Dr. Harpinder Singh to discuss the radiology of this patient. Thank you.
Good afternoon, everyone. So first we have this frontal radiograph chest of the patient. And here in retrocardiac location, we can see there is this lobulated mass that is forming broad base towards the mediastinum. Its contour can be traced below the level of diaphragmatic dome. Cranially, it is traceable till the right main bronchus. However, there is no mass effect on the right main bronchus. Rest of the bilateral lung fields are clear and all the visualized bones are normal. So based on this, these findings are suggestive of a posterior mediastinal mass. And to characterize it further, we did a CCT chest and abdomen with oral contrast. So these are the sagittal and axial soft tissue window images. The CT was performed with oral contrast at the time of acquisition. So this is the anterior wall of esophagus. This is the posterior wall. And here we can see there is air fluid level formed by the orally administered contrast. So in the interior wall, we can see there is this homogeneously enhancing mass that shows these tiny foci of calcification within. It does not show any cystic change or necrotic change. Anteriorly, it is forming around 90-degree angle with the anterior wall, suggestive of the intramural location of the mass. Anteriorly, the fat planes with the heart and pericardium are maintained. Laterally, it is not infiltrating the lung parenchyma. Posterolaterally, we can see there is focal loss of fat planes of less than 90 degree with the descending thoracic aorta. And caudally, it is extending till the level of gastroesophageal junction. Here we can see there are no significantly enlarged mediastinal lymph nodes or subdiaphragmatic lymph nodes. Bilateral lung fields are clear and the acquired abdominal sections were unremarkable as well. So to summarize, we have this homogeneous, well-defined mass, which is not showing any evidence of infiltration into the adjacent structures. It shows calcific foci within, and despite its large size, it does not show any necrosis within. and there are no significantly enlarged regional or distal lymph nodes. So these features are suggestive of a benign esophageal neoplasm, likely a leiomyoma. The points against GIST are, for such a large mass, GIST would have shown focus of necrosis within. So next I will call Dr. Shakshi.
Good afternoon. An endoscopic ultrasound was done at an outside center which identified a submucosal lesion at the lower end of the esophagus with differentials of a gastrointestinal stromal tumor or a leiomyoma. Biopsies were taken. Microscopic examination showed a low-grade benign spindle cell neoplasm, and the immunohistochemistry testing was done, and a final impression of leiomyoma was given. After all the pre-op evaluation, a final diagnosis of esophageal leiomyoma, annular type, which was located in the middle and lower third of the esophagus, was made, and the patient was planned for a left thoracotomy with enucleation of the tumor, and esophagectomy was kept as a backup option. There were a few challenges in our case. It was a large tumor which was almost encircling the esophagus and located in the middle and lower third of the esophagus up to the gastroesophageal junction. We anticipated extensive mucosal adhesions due to previous biopsies. Keeping all of these factors in mind, we chose thoracotomy as our preferred surgical approach. Prior to surgery, we had also anticipated a need for esophagectomy, and the consent was same with gastric pull-up as reconstruction option was explained to the patient. We approached from the left side as it is easier to access the gastroesophageal junction from the left. The patient underwent a left anterolateral thoracotomy with complete enucleation of the tumor. Coming to the operative details, after giving general anesthesia, a double lumen tube was placed for selective ventilation of the lungs. The patient was placed in right lateral decubitus position, and an anterolateral thoracotomy, the incision was given on the left side in the sixth intercostal space. The chest cavity was opened in layers. After entering the chest cavity, the left lung was deflated using the DLT tube. The esophagus was dissected and the gastroesophageal junction was identified. Incision was given over the esophagus to open the adventitia. A myotomy incision was made and the tumor was identified. The picture here shows after myotomy incision, the tumor was visible. Stay sutures were placed at the ends of the tumor to help with the retraction. The tumor was dissected all around in the submucosal plane, keeping in mind not to open up the mucosa, and the tumor was completely enucleated. During dissection, the mucosa opened up at a place which was repaired using PDS sutures, which is a delayed absorbable suture. To check the integrity of the mucosal repair, we did a leak test using methylene blue. The nasogastric tube was placed and methylene blue was administered through the tube, which confirmed no leak from the mucosa. The muscle layer was closed using absorbable sutures and the lung was inflated under vision. The chest wall was closed in layers. The specimen here shows a large multilobulated tumor which is spanning across the lower esophagus and going into the gastroesophageal junction. On cut section, we can see a smooth homogeneous appearance of the tumor with no grossly identifiable areas of any cystic changes or any necrosis. The postoperative period was uneventful. On postoperative day 5, a gastrographin study was done and the patient was allowed orally. On postoperative day 6, the lungs were seen well expanded on the chest X-ray and the intercostal drainage tubes were removed. The patient was discharged on postoperative day 7. On his first follow-up visit, on 2 weeks after the surgery, the patient was doing well. He was taking adequate oral diet. The surgical site was healthy and the sutures were removed. 1.5 years after the surgery, the patient was doing well with no similar symptoms. I now invite Dr. Snehavarsha for pathology.
Good afternoon, everyone. We received a large multinodular tumor which had a smooth surface, and on cut surface we can see it is very fleshy, firm, white, grey white in color with whorled appearance. So then we did a microscopy of it and we can see that the tumor is very well circumscribed. This is a capsule of the tumor and it shows a low grade spindle cell morphology. The tumor cells are arranged in a fascicular pattern. So this is the area showing hypocellular spindle cell areas. These cells show mild nucleopleomorphism. They are elongated with blunted ends, and there was minimal nucleopleomorphism. No areas of mitosis or necrosis was noted. So the adjacent area showed edema, scattered vessels, and scant chronic inflammation and hyalinization as well as areas of calcification. Then we performed immunostain, and these cells were diffusely immunopositive for SMA, ruling in smooth muscle differentiation, and dog one was negative, ruling out GIST. So we gave a diagnosis of leiomyoma. Now I would request Dr. Reva to take over.
So, very good afternoon, everyone. So, we are talking about the esophageal leiomyoma, which is the most common benign esophageal tumor. Although it's the most common benign tumor, but still it is much less common than the more common etiology, that is esophageal carcinoma. So, they are basically arising from muscle layers from the esophagus, and we can see that here we have two muscular layers. One is the muscularis propria, which is the outside layer, and then in the mucosal layer we also have a here shown by the blue one, which is the muscularis mucosa. So they can arise from both these layers, but the most commonly it is arising from the muscularis propria layer. So they are seen in the third to fifth decade with a more male preponderance. The incidence varies in various studies. It is from 0.005 to 5%. They are mostly single and are less than 5 centimeters in size, but there can be multiple leiomyomas in up to 4% of cases. And if they are more than 10 centimeters, such as an R case, they are known as giant esophageal leiomyoma. So, to the best of our knowledge, with our literature review, we found that there are less than 20 cases of giant esophageal leiomyoma reported in the world. Now, according to the growth patterns, they are classified as shown here. So, the intramural one is the most common pathology, and the annular one, which we had dealt with here, is the least common one, which is seen in only 2% of the cases. It is also classified according to the location. So it is most common in the lower esophagus, followed by the middle one, and then the upper esophagus. So the symptoms in esophageal leiomyoma are pretty non-specific, and they are mostly long-standing. The patient can complain of dysphagia, pain, retrosternal discomfort, weight loss, compression of the airway by the tumor, or an upper GI bleed due to erosions in the esophageal mucosa. So the diagnosis is usually made by various modalities, including the imaging. The traditional imaging modalities include a chest X-ray, barium swallow, a computed tomography, or an MRI. The endoscopy is usually done as an evaluation of dysphagia. It is also performed for assessment of the mucosa. And the biopsy is usually not recommended as it leads to adhesions of the mucosa with the underlying tumor, making the surgical enucleation difficult. And the gold standard investigation in such cases where we suspect an esophageal leiomyoma or a GIST is the endoscopic ultrasound. So, why? Because it can precisely characterize the layer of origin. So, like in this case, this is just a picture shown from a study. So, we can see that this white layer here, which is the hyperechoic one, that is the submucosa, and after that the hypoechoic layer one is the proper muscular layer, and we can see that this lesion is here in the muscularis propria layer. So this is most likely a leiomyoma arising from the muscularis propria layer. So the treatment options for such lesions include a thoracotomy with enucleation or an esophagectomy with a newer modalities like video assisted or robotic assisted thoracoscopic surgery, and the most recent one is submucosal tunneling with endoscopic resection, which is performed by our gastroenterology colleagues, which is also done for a very small lesion like 2 or 3 centimeter lesions. Now the traditional approach is a thoracotomy with enucleation. The esophagectomy is only considered if there's a large mass, if they are circumferential or annular, if we have extensive adhesions between mass and mucosa, which leads to irreparable tears in the mucosa. Now,
To compare various modalities, we found that this is the largest systematic review and meta-analysis which is performed for treatment options in esophageal leiomyoma. This includes around 300 patients, where we can see that the mean tumor size is almost double in thoracotomy when compared to VATS. In this meta-analysis, they found that with VATS, there is shorter operative time, there is less of blood loss, and less of post-operative stay in the hospital. But they found that there were no significant differences between the pleural drainage day, that means the days of ICD in situ, as well as the post-operative complications. This is another single center experience of surgeons. So they found that in 13 years they had operated on 34 patients, where they had performed thoracotomy in 10 cases, and in 24 they had performed a thoracoscopic surgery, with the mean tumor size being only 5 centimeter. The largest tumor recorded here was a 10 centimeter tumor. And in retrospective analysis, they found that when the tumor was encircling the esophagus and when they had to approach from the left side, they had preferred a thoracotomy approach instead of thoracoscopic approach. So now, with recent advances, there have been multiple reports of giant esophageal leiomyoma being tackled with thoracoscopic surgery or VAT surgery. So these are various reports where they had performed thoracoscopic enucleation, and the largest one recorded here was 22.5 centimeter, which was published from Beijing, China, where they had operated on a 26-year-old male who had a leiomyoma of the middle esophagus. Now I would like to invite Dr. Devinder Singh sir, Assistant Professor in Surgery Department, for the concluding remarks.
Thank you, Dr. Riva. Indeed, it was a challenging and rare case, which was very well managed by enucleation, which is the recommended and preferred treatment. However, the treatment should be tailored based upon tumor size, the growth pattern, and location of the tumor. For small tumors less than 5 centimeter, minimal assist treatments like video-assisted thoracoscopic surgery or robotic-assisted thoracoscopic surgery is preferred one. But for large tumors, as in our case, more than 10 centimeter, and for annular types, which encompasses the whole lumen of the esophagus, thoracotomy is the preferred one. Biopsy should not be done unless and until there is some doubt on imaging. If imaging is confirmatory of benign finding, then we can go ahead directly with surgery. So, before final conclusion, I would request Professor Sunil Chumbar sir, the operating surgeon, to give his experience on this rare entity. I will open the house for any questions. Dr. Anand, please, you can share your experience.
It is associated with leiomyoma elsewhere. You have a leiomyoma in the esophagus. Will you also get leiomyoma?
Sir, leiomyoma can be in other sites also, but the most commonly it is in esophagus. They can be arise from any muscular wall of the bowel. No?
When you have an esophageal leiomyoma, you also need to look for leiomyoma elsewhere as part of the water. But is it usually an isolated view?
This is not, on imaging we have confirmed that it is a single leiomyoma, but some reports are there that there are multiple, 2 to 3. Like in the Beijing one, there were 2 leiomyoma at separate locations.
In syndrome, mostly they are female. So, the one important thing is in part of the lab. We do the lab, inner side, rear and the writing skill, that should not be done. That's one method. Another rare case, and we have mostly the weak one in this case.
Sir, mostly it is not if it is excised completely. So recurrence is not seen. It is a completely benign thing. No? So recurrence is usually not reported after leiomyomas.
We do get equal graded biopsies from leiomyomas that are based see mostly they're circumscribed, but yes, sometimes there is a leiomyomatosis. So you can't actually see the extent and then it is a problem. So that's why they should be evaluated for multiple lesions. And in the female, especially this leiomyomatosis, so that is more difficult to take out. So that's why a complete evaluation should always be there. And they're uncommon. And gist is a differential, so that's also biopsy why it becomes important. Because if it is a gist, so gist is very uncommon in esophagus, but then you will give it in it, and in leiomyoma you are not going to give it. We have 4 in the last 15, 20 years, so they are much more uncommon. Even these are also not common, and gist is much more uncommon than leiomyoma. Yeah, but the see if it is a 15 centimeter, if you take it out and it turns out to be a gist.
There is still a possibility we can do the split.
Yes.
If the margin is positive and there is a high
But still we get biopsies. But this is not
but
like
biopsy I think should not be done.
yeah, it should not be done,
Yeah.
but yes, still it is done.
What is the characteristics?
So there is no hormonal treatment given per se for these lesions. 1-2 cases I remember which were like leiomyomatosis. So we could not even make out actually the rest of the esophagus which was looking normal, that also had changes of this leiomyoma-like features on histology. So those I don't know if they have been given any adjuvant, but as such there is no hormonal therapy, so nothing like ER or against the you can do anything like happens with the uterine. So these are different per se as compared to the uterine leiomyomas, which are very, very common. So these are quite uncommon that way. We see like once in 6 months or a year like that. This was a male patient.
Yes, ma'am. Male patient. The interesting thing is that patient was that it was near the GE junction, so there was risk of post-operative GRD, but we evaluated it, and there is no evidence of any GRD. And secondly, we were keeping the plan of backup plan of esophagectomy because it was annular type. If the mucosal tears were too much, then we have to go for more morbid procedure, that is esophagectomy.